talking about tubular reabsorption, and maximum tubular reabsorption occurs in the proximal convoluted tubule. This is going to happen in the proximal convoluted tubule, and as I told you, in the proximal convoluted tubule, most of the reabsorption percentages are more or less fixed. So even if the body requires more of a particular substance, it's not going to happen in the PCT. So 60 to 70 or almost close to 80% of water gets reabsorbed here. The same percentage of sodium, potassium gets reabsorbed, and then what gets reabsorbed 100% is your glucose, amino acids, vitamins, fatty acids. These are all 100% reabsorbed, okay? And the type of transport, we looked at how each one gets transported. So sodium is primary active transport. Why is everybody peeping in and not coming in? Primary active transport. Glucose, amino acids, vitamins, all of these are active transport along with sodium. Okay, so you need sodium for reabsorption. Anything that is fat soluble can easily go through by simple diffusion, and so that's passive. Water is osmosis, and negatively charged ions like chloride usually get attracted by the positively charged ions that are reabsorbed. So this slide is important in the sense it tells you some of the important things that are reabsorbed and the mechanism of transport. So keep this summary, this slide, when you are studying for this. Now, if you look at most of the substances that are being reabsorbed, you can see that there are transport proteins. Okay, so this circle represents a transport protein. So sodium binds to one end of the protein, glucose or amino acids or vitamins will bind to the other side of the protein, and the whole thing gets transported. Now there are transport proteins for each individual substance. So you have something called glucose transporters. Then for every amino acid, so we have about 20 amino acids, each amino acid has a specific transport protein. Vitamins have their own transport protein. Okay, so when you look at the transport of these substances, when you look at the transport of organic molecules, every substance has a maximum amount that can be transported at any given time. So as the filtrate flows through the proximal convoluted tubule, the filtrate has a lot of glucose, amino acids, but as the filtrate is flowing at any given time, there is a maximum amount that the proximal convoluted tubule can reabsorb. Okay? A maximum amount that can be reabsorbed from the filtrate at any given time as the filtrate flows through the PCT. Okay. And this maximum amount that can be reabsorbed depends on the number of transport proteins available for that substance. So to give you a very crude example, if you have 20 transport proteins for glucose and sodium, at any one time only 20 molecules of glucose will be able to get reabsorbed as the filtrate flows through. So anything more than 20 cannot be reabsorbed. Okay? So that is what this is. So for every substance there is a maximum amount that can be reabsorbed. And we call this is called the transport maximum. The term that's given for this is called transport maximum, or we write it like this, Tm. This is how it is represented. So there is a transport maximum for glucose, there is a transport maximum for a vitamin, for different amino acids, there is a transport maximum, and there is a way to calculate it also. Okay, if you go deeper into urinary physiology, you can actually calculate the transport maximum. Okay. So what this essentially means is that if all the transport proteins are saturated, they are bound to glucose, if there is extra glucose in the filtrate, it will not get reabsorbed, it will just have to pass, okay, until the next lot comes. So the filtrate is constantly flowing. So based on how many transport proteins are available, only that much gets transported. But then we also know, another thing that you already know now is normal urine does not have any glucose. No glucose is found in urine. And we said that 100% of glucose gets reabsorbed in the proximal convoluted tubule. So that means in a healthy person, the amount of glucose that is filtered never exceeds the transport maximum. It never is higher than that. So whatever glucose is filtered at the glomerulus, glucose is a small molecule, everything gets filtered. Whatever glucose is filtered is always less than the amount of transport proteins that are available. So everything gets transported. So by the time the filtrate moves from the proximal convoluted tubule into the descending limb, there is no glucose in the filtrate in a normal person. But this is not the case in a person who's a diabetic. Or let's say on one particular day during lunch, you have a heavy carbohydrate meal and your blood glucose level goes up. Then you might find glucose in urine, because the amount of glucose is higher than what the PCT is able to handle. It's not able to reabsorb everything. Okay? But in general, in a normal person, the amount of glucose that is filtered never exceeds the transport maximum. Okay? It's never higher than that. So let's see what happens in a diabetic person. Why in a diabetic individual do you see glucose in urine? Okay? So let's do it as a flow chart, which will be, when you're studying, when you're trying to understand something, it's always a good idea to look at it in a sequential manner, what is happening. So in, let's say, diabetes mellitus, we are all familiar with this situation. What is this condition? Diabetes mellitus is usually decreased or lack of insulin secretion, or it could be the resistance to insulin, whatever, but basically it's insulin that is the main culprit. Okay? And because in this case, what is going to happen? Cells are not able to use the glucose, glucose cannot enter the cells, so blood glucose levels increase. Blood glucose levels increase in a person who's not on any kind of treatment. Now, normal blood glucose levels, normal fasting blood glucose levels is generally between 70 to 110 milligrams of glucose in every 100 ml of blood. Okay, this is to just so that you have an idea, not necessarily you have to memorize it, but you have an idea. So in the morning when you wake up and test your blood glucose levels, a healthy person should have anywhere between 70 to 110. After a meal, after you've had your lunch or dinner or whatever, your blood glucose levels goes up because obviously things are getting absorbed. So this value will then become about 140 or 160 milligrams. Okay, it will go up. And then within about 2 hours after a meal, the level should come back to normal. That indicates that your body is secreting enough insulin and the glucose is being used up by the cells. Okay? But in a diabetic person, the blood sugar levels are high. Okay? So generally it is higher than, greater than or equal to about 180 milligrams in every 100 ml of blood. So it goes up. In a normal person it can go up to 160, 170 or so, but in diabetics it can go beyond this, 200, 220 after a meal. Okay, or even their fasting level, if they are not properly taking medications, their fasting glucose could also be pretty high. So when something like this happens, okay, blood sugar levels are high, you know that glucose is a small molecule, it gets filtered. So the amount of glucose in the glomerular filtrate will also be high accordingly, because the blood sugar levels are high, blood glucose levels are high. So obviously the glomerular filtrate, every minute the filtrate is going to have a lot more glucose. Okay? So what does this indicate? This indicates that the amount of glucose in the filtrate will be higher than the transport maximum for glucose. So it's going to be higher than what the PCT can reabsorb. The moment the blood sugar level goes above 180, that means a lot of glucose gets filtered, and it is definitely going to be more than what the PCT can handle. Okay? So in this case, what is going to happen when something like this, when the amount exceeds the transport maximum, the next step would be all the glucose in the filtrate does not get reabsorbed. In the proximal convoluted tubule. So all of it cannot get reabsorbed. Okay. The remaining glucose enters the loop of Henle and DCT and collecting duct and gets excreted in urine. Now you might think, okay, why not? Once it has gone from the PCT to the loop or the DCT and the collecting duct, why does it not get reabsorbed? It doesn't get reabsorbed because you don't have these transport proteins. They don't have these transporters. So the cells that line your loop and your DCT and CD collecting duct do not have those specific transporters. So it just comes out in urine. Whatever is excess comes out in urine. The same thing applies for amino acids. The same thing applies for water-soluble vitamins. All of them have specific transport proteins, and the proximal convoluted tubule is where you find the transport proteins. That's why maximum reabsorption occurs in the proximal convoluted tubule, because the specific transporters are located in the cells, the cuboidal cells that line the proximal convoluted tubule. You don't get them anywhere else. So that's why glucose, you find glucose in urine whenever the amount of glucose in blood exceeds the transport maximum. Okay? So this is the cutoff point, 180 milligrams. As long as your blood sugar levels are less than 180, even after a meal, as long as your blood sugar levels do not go over 180, you're fine. All the glucose will get reabsorbed. So even if you have a heavy carbohydrate meal, if your blood sugar level stays within 180, you're fine. You will, even if you test your urine, you will not find glucose in it. But the moment your blood sugar level goes, this is blood sugar level, the moment your blood sugar level goes higher than 180, you will definitely find glucose in urine. We call it glycosuria or glucosuria. Now the same applies for any other substance. Let's say you're a young, healthy individual. You are on a balanced diet, but yet you have the fad of, taking vitamins, supplements, just like that. Just because somebody said, oh, those vitamins really give you a lot of energy and strength. So you buy these vitamin supplements and you take it. Okay, these are water-soluble vitamins, B complex vitamins and all that. Okay, you take it. So when you take those supplements and you are still a healthy person on a proper diet, your body will only use whatever it needs. So these vitamins are going to be filtered at the glomerulus. And the amount, if the amount of the vitamin in the filtrate exceeds the maximum for that vitamin, you will have vitamins excreted in urine. Okay, it's literally water or money going down the drain. You are going to pee it off. Any excess is going to come out. The same holds for people who are, used to drinking protein drinks. If they are not bodybuilders, if they're not building muscle, but yet they take some of these protein shakes, then your body is only going to absorb what it needs. The rest of the amino acids are going to come out in urine, because every substance has this transport maximum. Is that making sense to you? So that's why you find glucose in urine. So here I would like to emphasize something. If you say that, if you test urine and you find plasma proteins in it, you find albumin, globulin in it, you know that plasma proteins don't get filtered because they are too large. So if you find proteins in urine, one likely cause is that nephron is damaged. Okay? But if you find glucose in urine, that doesn't mean the nephron is damaged. It means that the amount of glucose in the filtrate is higher than the transport maximum. Do you understand the difference in the reason for both? Okay? That's the thing. Do you have a question? This is something to understand why you see glucose in urine in a diabetic person. Okay? Right. Now we come to tubular secretion. So tubular secretion is the opposite of reabsorption, where the substance is going to get from the blood into the filtrate. And I told you tubular secretion happens because of two reasons. One, if the substance that needs to be thrown out of the body escapes filtration. So as the blood is flowing through the capillary, it somehow escapes it and gets into the peritubular capillary. So you need to have a second mechanism to throw it out. So that's where tubular secretion comes. And it's also for substances that are too big to be filtered, especially the breakdown product of drugs. Okay? So, tubular secretion happens throughout the nephron. PCT, loop, DCT, collecting duct. Tubular secretion, unlike reabsorption, which is mainly concentrated in the PCT, this can happen everywhere. So, what are the things that usually are thrown out by tubular secretion? Acids, creatinine, which is a throwaway product, most of it gets filtered, but about 20% has to be secreted. Potassium, ammonia, uric acid, all of these acids which come from your diet, okay? And of course, drugs, if you're taking medications, the breakdown product of drugs. And tubular secretion is generally an active process. You need energy because these are larger molecules, so you have to push them out. So you need energy for it. Unlike reabsorption, which can be passive or active, this is more of an active process. Okay? So now let's come to the distal nephron. Okay? The distal nephron is where fine tuning of the filtrate takes place. And this is what we were talking about. So this is where the body can adjust what it needs. According to its needs, it can increase the amount of water that it reabsorbs, or it can throw away the water. It can increase or decrease the salt reabsorption, whatever is needed according to the body's needs. Okay? So when you say distal nephron, we are talking about the DCT and collecting duct. Now you must be wondering, I skipped the loop, but we will come to that because the loop has a very specific function. So let's look at the distal nephron, the DCT and the collecting duct. This is where fine tuning of the filtrate takes place based on body requirements. And this is where majority of the hormones act here. Most of the hormones are going to act here. And many of them you already know. Okay? First and foremost, aldosterone. Okay? Aldosterone. And it is in the distal nephron that the receptors for the hormones are here. I mean, this doesn't mean that there are no hormones that act on the PCT. There are some hormones that do have some mild effect there, but majority of the hormones, the receptor, the hormone has to bind to a receptor. If it is a water-soluble hormone, it will bind to a receptor on the cell membrane. If it is a steroid hormone, it will go into the cell and bind to cytoplasmic receptors. So the receptors for the hormones are all located in the DCT and the collecting duct. So that's why major action of hormones is in the DCT and collecting duct. So aldosterone, if you remember, this is a steroid hormone. This is a steroid hormone. It is secreted by the adrenal cortex. And now you'll be able to understand the name. The layer that secretes aldosterone is called the zona glomerulosa. So now you're able to relate where this glomerulosa comes from, because it acts on the kidney. That's why it's called glomerulosa. Okay, zona glomerulosa. And what does aldosterone do? You already know this, renin-angiotensin-aldosterone system. Aldosterone has a dual effect. So if you look at the transport protein, once aldosterone brings about its action, there is a transport protein. Sodium gets reabsorbed from the filtrate into the peritubular capillary, and at the same time, the same transport protein will pump out from the capillary, it will pump out either acid or potassium. So potassium is thrown out. So any day that you are consuming 2 or 3 bananas, your potassium levels go up. So that potassium has to be removed. Okay. So for this, why potassium, you have to remember. So blood sodium levels. And I think I've mentioned this to you before, but it's always a good idea to remember this. Blood sodium levels are anywhere between 135 to 145 millimoles per liter of blood. This is your blood sodium levels, salt levels. Blood potassium levels, much, much lower, 3 to 5 millimoles per liter. So look at the big difference. So potassium levels have to be kept very, very low in blood if you want your nerves and your muscles to function properly, because potassium is responsible for the resting membrane potential. So the moment this changes, if this increases or decreases, it will definitely have an effect on muscle function, nerve function. So the body controls potassium levels very, very strictly. Okay, you don't, and even in the hospital, when you are administering potassium, you have to be very careful. Okay, especially IV and all, you have to be very careful. So, because it can suddenly disrupt the resting membrane potential, heart can stop. So you have to be very careful. So what aldosterone does is it reabsorbs sodium from the filtrate. Okay, so reabsorb sodium from the filtrate, and always remember sodium is an osmotic substance. So when sodium gets reabsorbed, it pulls the water along with it by osmosis. So it is not just sodium. So when we write the action of aldosterone, this is how we write: reabsorb sodium, and then within parentheses we will write water. That means water follows. Okay, from the filtrate. And the second effect is it causes secretion of potassium or hydrogen ions, acid, from the blood into the filtrate. So there is a tubular reabsorption and secretion happening at the same time. Okay. So because of this effect, that's why aldosterone is involved in blood volume and blood pressure regulation, because it reabsorbs sodium. And in exchange for that, it throws out potassium or hydrogen ions. So that's the first hormone. Okay. Aldosterone is the first one. Now let's look at the second hormone. So this is where, so the same way in the PCT, calcium is also reabsorbed. Sodium, potassium, calcium. So let's say about 70 to 80% of calcium gets reabsorbed. But let's say it's a pregnant woman and she needs extra calcium. Okay. So where does that adjustment happen? It happens in the distal nephron under the influence of, you also know this, parathyroid hormone. Parathyroid hormone, which is, again, this is actually a protein hormone, so it's not a steroid. And this is secreted by the parathyroid gland. You know that, parathyroid gland. And the role of the parathyroid hormone is to increase tubular reabsorption of calcium from the filtrate. From the filtrate, same thing. Okay. Now the third hormone, which is the opposite of aldosterone. Aldosterone reabsorbs sodium. Now let's say that you have someone who's on a very high salt diet, loves to add extra salt to the food. So then to maintain homeostasis, the extra salt has to be thrown out. So you have another hormone which is exactly the opposite of aldosterone, and this is called atrial natriuretic or natriuretic hormone. Some books will say peptide. Okay, now it's confirmed that it's a hormone. So atrial natriuretic. Natriuretic. So in order to understand this word, because sometimes once you understand the meaning, it's easier. Uretic means in urine, just like emia means in blood, anemia, polycythemia. So EMIA means blood, hypoxemia. All that is blood, in blood. Uretic means in urine. Natrium. Natrium is the Latin name for sodium. And that's why the chemical, you represent sodium as Na+, because it comes from this Latin word natrium. For potassium, the Latin word is kalium. Kalium. So that's why you write K+. The symbol is K+. So natriuretic hormone, sodium in urine. So this is a hormone that will throw out sodium in urine, and atrial comes from where it is secreted. So this hormone is secreted by the atrial cardiac muscle cells, okay, especially right atrium, secreted by atrial muscle. So there you go, the heart is also an endocrine organ. Okay, and what does this do? Exactly the opposite. It decreases tubular reabsorption of sodium. So now we are talking about the distal convoluted tubule and collecting duct. It decreases tubular reabsorption of sodium, and because sodium doesn't get reabsorbed, water will also not get reabsorbed. Okay, so in the end, what is this going to do? It is going to increase sodium and water in urine. And when it does this, when sodium and water is removed in urine, it is going to decrease blood volume and decrease blood pressure. So the trigger for release of this hormone is increased blood volume and increased blood pressure, mainly volume. Okay? So that is the three. Okay, we're talking about three of them. Now the fourth most important one, which you already all know about, is ADH, antidiuretic hormone, which comes from your posterior pituitary. Now to understand how ADH, you all know it increases water reabsorption. So the role of ADH in the distal convoluted tubule and collecting duct is to increase reabsorption of water. Pure water. There is no sodium or anything along with it like aldosterone. It's pure water. Okay? In order to understand how ADH is able to pull the water out of the distal convoluted tubule and collecting duct, this is where we need to understand the function of the loop. So the loop plays an important role to sort of lay the ground for ADH to do its job. Okay? So the loop itself is not involved in anything, but the loop is making it easier for ADH to do its action on the DCT and the collecting duct. So this is the complex part of this fine tuning. Again, here I'm going to not go into the details because this, even medical students have great difficulty in understanding this whole thing, and Christine, you were talking about it the other day, you know, the countercurrent mechanism. It's not easy to understand this, but I'm going to break it down, make it as simple as possible, just so that you're able to understand how ADH is able to pull water out of the distal convoluted tubule and the collecting duct. Now, before we start, okay, before we look at what is the role of the loop of Henle, I want you to tell me this. Let's say I have a beaker here. I have a beaker, and then this is separated by, I have an artificial membrane here. This is a membrane that allows only water molecules to pass. And if I want water to move from A to B, what should I do to make water move from A to B? Both of them have just water in it. So how will I make water move in one direction only?
The pressure higher in A.
Okay, pressure is one. Solute.
Osmotic pressure.
Which osmotic pressure? Which side would you add the solute, the salt?
You would want to add it into.
Which side would you add the solute? Side A or B?
Side
B.
B.
So that the water goes into the B side to make the.
Exactly. So you want to add salt here so that solution B becomes concentrated or hypertonic. Only then water will move from A to B. Is that making sense to you? Okay. So remember this. So if you want water to move preferentially from one compartment to another compartment, there must be an osmotic pressure difference. Okay. One side must be more concentrated, the other side should be dilute. So this should be dilute and B should be concentrated. Only then you can make water move. Okay. Keep that in mind. Keep this in mind. And now we will see what the loop does and how ADH is able to perform its function. So this is your cup, and then this is your PCT, and then here's your loop. Okay, let's draw this a little wider. Okay, and then comes your DCT and collecting duct. Descending limb, ascending limb. And this part, so let's do this also. This is the cortex. This is the medulla. Okay. And this space that you see, this is the interstitium, the space, tissue space. Okay. All of this is the tissue space, which is generally filled up with a little bit of connective tissue and some fluid as well. It's not a dry space. It is a wet space. There's a little bit of fluid. So this is called the cortical interstitium. This is the medullary interstitium. And here would be your papilla. Now, when the filtrate enters the descending limb of the loop of Henle, this filtrate will have roughly about 80 to 85% reabsorption occurs here. So it's going to have about 15 to 20% water, sodium, chloride, okay, calcium, just arbitrarily, all of the dissolved salts will be there. Okay, because most of them are reabsorbed there. So it still has about 15 to 20% of all this. What is not going to be there? It's not going to have no glucose, no amino acids, fatty acids, okay, none of those things. It will have waste products, okay, it will have some acids, creatinine, bilirubin, all of that is going to be there, which has to be thrown out. So as the filtrate moves down the descending limb, okay, so this is the descending limb. The descending limb is permeable to water and water alone. So the structure of the descending limb is such that it is permeable to water. It allows water to come out into this interstitial space. So as water comes out, all of these dissolved salts are still inside, because this descending limb does not allow solutes to escape. It does not allow solutes to come out. So as water goes out, this inside, the filtrate is going to become concentrated. And by the time it reaches the tip of the loop, it is really salty here. It's very salty because water has come out. Now this filtrate will start moving upwards now, because the loop loops around and it goes up. Okay? Because the filtrate is flowing in two directions in the loop, we call this counter current, because one side it is going down, the other side it is going up. So this type of flow of fluid is called counter current flow. Counter current flow. Where do you see this counter current flow? In the loop. Okay, because one side is coming down, the other side the filtrate is going up. Now, this ascending limb is the one that is key. What the ascending limb, if you look at the ascending limb has a lot of transport proteins. So these are all transport proteins. What is this going to transport? It actively transports, okay, this is active transport. It actively transports sodium, potassium, and chloride out of the filtrate into the interstitium. So sodium, potassium, chloride. So these transporters that you find in the ascending limb of the loop of Henle, they are called sodium, potassium, 2-chloride transporters. These are active transport. That means energy is used up to bring them out. Okay? And unlike, yes, I'll come to your question. Unlike the PCT, without going into too many details, in the PCT, sodium does get reabsorbed, chloride does get reabsorbed, but it ultimately enters the blood. Unlike the PCT, here in the loop, the salt remains in the interstitium. It remains in the interstitium. It doesn't get into the blood, because the blood flow is also such that it stays here. Okay, I'm not going to go into the details of the blood flow, okay, which is, you know, it's easy to understand but sometimes can be confusing, so I will not go into the blood flow. But just remember that these substances, these electrolytes that are being pulled out of the ascending limb of the loop of Henle, they remain in the interstitium. They don't go off. They don't get into the blood. Okay? So, since they remain here, this interstitium is going to become salty and salty and salty as the child grows up. After it is born, it starts consuming, initially it is milk and then it starts consuming food. So as the diet changes, more and more sodium, potassium and chloride keeps getting added to the medullary interstitium. So ultimately this medullary interstitium becomes hypertonic over a period of time. Over a period of time, the medullary interstitium becomes hypertonic because this is constantly going on. So descending limb is permeable to water. Ascending limb, not permeable to water, it only pumps the salt out. And this salt remains here, making the interstitium more and more salty. Okay, so if you actually measure the saltiness of the interstitium, at this junction where you have the cortex and the medulla, that's where it is starting. So this will be, there are values, this will be around pretty much the same salt levels as your blood, 300 milliosmoles. But as you go deeper, if you take a piece of tissue and taste it, it will be salty. By the time it reaches the tip, it is almost from 300, it will become almost 1200 to 1400 milliosmoles per liter. That means that much of salt gets accumulated as the filtrate keeps going up and down. Okay. Now you can understand, you have made the outside salty. So if you need to take the water out here, water will easily come out because your filtrate is dilute. Your filtrate is dilute and water can be easily pulled out under the effect of ADH. If ADH is present, water can be easily pulled out because this side is dilute, outside is hypertonic. So water can be easily drawn out. So the purpose of the loop is just to make the medullary interstitium hypertonic. That's it. The loop itself has no main function. Not reabsorption, no secretion occurs to a certain extent. But the main function of that loop is to make this interstitium salty so that if ADH is available, water can be drawn out. Okay, so let me do this and then I'll come to your question. So under the influence of ADH, if ADH is secreted by the posterior pituitary gland, ADH will have an effect on the DCT and the collecting duct and it will make that portion of the nephron permeable to water. So it will add water transporters so that water can easily come out. Okay. But if ADH is not being secreted, if the body does not require extra water, the DCT and the collecting duct will not be permeable to water. So the urine that comes out is going to be extremely watery. It's going to be dilute. So with the help of ADH and with the help of this loop that creates this hypertonic interstitium, the body can reabsorb water if needed, or it can throw out the excess water in urine if it is not necessary. So this mechanism which happens in the loop to make this medullary interstitium salty is called the counter current mechanism because the flow of liquid is in two directions. So it's called the counter current mechanism. So the loop itself is called the counter current multiplier because it makes it more and more salty. The blood vessels that travel with it, they are called the countercurrent exchangers, so that the blood vessels make sure that the salt remains here and doesn't get washed out, doesn't go off into the blood. Okay, so a little complex process to understand, but I don't want you to, stress yourself over that. Main thing, because, and I'll tell you why whatever little I told you is important, because when we talk about drugs, you will understand. Okay, so let me talk about the drugs and then I'll come to your question. I know Meredith had a question, you had a question. So
it was about vasopressin and furosemide, so you'll probably...
Exactly, yeah, that's where we are coming, yes. So vasopressin is the other name for ADH, right? So this one, let me, so before we go to that, let me ask you this. Suppose a person is dehydrated, not taking water, okay? You're all going to be working in healthcare, and there may be days when you're so busy that you don't get time for a drink or food, okay? So when your body does not have enough water, what will happen to ADH secretion on those days? Will increase. Very good. ADH secretion will increase. Okay? And when ADH secretion increases, there will be increased water reabsorption from the distal convoluted tubule and collecting duct. What will happen to urine volume in this case? Urine volume, when you are reabsorbing water, what will happen to the amount of urine that you pass on a day when you don't drink enough liquids? It will decrease. Urine volume is going to decrease. And what will happen to the concentration? Is it going to be highly concentrated or less concentrated? Increased concentration. Okay. The opposite will happen when you are overhydrated. When you drink a lot of water, your body doesn't need extra water, so it needs to throw it out. So ADH secretion is suppressed and the water gets thrown out in urine. It will be a dilute urine, that large volume of dilute urine that will pass out. Okay. Now let me ask you this question and then, so think about this. In a newborn baby, will the action of ADH be effective in a newborn baby or a very young infant, the first few months of life?
No.
Will they be able to, let's say a child has, this little baby has vomiting and diarrhea. Can you just wait and keep them at home and see whether things will be okay? No. Why? Because they'll get dehydrated very quickly. Because they will not be, their medullary interstitium is not hypertonic yet. Okay? So they will not be able to pull water out. So in a newborn or in a young baby, concentration of urine is not possible. Why? Because this is not established yet. So that's why in a newborn baby, if they have one bout of vomiting or diarrhea, you have to take them to the hospital because they need fluids. Okay? Whereas as an adult, if you have food poisoning and you vomit twice, you can still wait at home because your body has the ability to retain water. Okay? So you can say, oh, let me try a few over-the-counter pills, and then if it doesn't stop, I'll go to the doctor. So you don't get dehydrated so quickly because your kidney has the ability to retain water. Okay? Whereas a newborn baby, no. A young baby, no. Because this gets established, this salt is going to get established only when you start feeding the baby. Once it starts milk feeds or top feeds, that's when this gets established. Okay. Now another question. If I administer a medicine and this medicine stops the action of this pump, okay, this pump that you have, sodium, potassium, it will not allow this pump to function. Okay, this pump will not function. So over a period of time, okay, if I administer this drug to somebody, what will happen to their urine volume? Think and tell me. You are stopping this pump. Once this pump stops, this pump is not working. So will salt be transported out? No. What will happen to the interstitium? Will it be as salty as before? No. It will become hypotonic, or the saltiness will reduce.
Or it'll become less hypertonic.
Once the saltiness reduces, can water come out easily? No. Less water will come out, right? So what will happen to urine volume? It will increase. Are you getting it?
Yes, because I was thinking totally on different, that decrease of the reabsorption of water will happen.
Yes.
That's what I was thinking.
Okay. Yes, so more urine volume. And this is exactly how furosemide acts, Lasix. Lasix blocks this pump. So these are called loop diuretics. Okay, so they block this. Okay, so a diuretic, so for a person who's having high blood pressure, one of the medications that you can use is blocking this. And the common name, it's very common in practice, Lasix, especially cardiac failure and all, they give them this. So these people are going to, because you're making this medullary interstitium less salty by blocking this pump, and then it will increase the volume of urine.
So,
That's also possible actually. If I block the transport of glucose in the proximal convoluted tubule, what will happen to urine volume?
where sugar goes, water goes.
Glucose is going to remain in the filtrate. Glucose is, again, just like sodium is an osmotic molecule, it will hold the water back. So glucose and water will get excreted in urine. So you can increase the urine volume by blocking glucose transport as well. So the moment you block some transport, it is going to hinder with water reabsorption. Yes. If you're ever asked what is the function of the loop of Henle, the main function of the loop of Henle is to create the hypertonic medullary interstitium. That is the only role which I would like you to just remember. Other than that, there is some reabsorption, secretion happening. But the main role of this long loop of Henle is to create the hypertonic medullary interstitium. And this in turn is needed for the action of ADH on the DCT and the collecting duct. Okay, that's about it. That's the main thing. Okay. And what is it that creates the medullary interstitium hypertonicity? It is the sodium potassium chloride pump, which is on the ascending limb of the loop of Henle, not the descending limb, ascending limb of the loop of Henle. That's where the pump is. And it pumps the potassium and the chloride out. If you go into details, you will see that. So this interstitial hypertonicity, this hypertonicity is because of sodium, potassium, chloride, and then there's a little bit of urea that also comes here. So some amount of urea is also part of this hypertonicity. But even if you forget that, that's fine. Remember this. So whenever you block this, you can increase the urine volume. Okay, so this is a very common drug that we use for many conditions. When you want to reduce the blood volume, when you want to reduce blood pressure, you need to remove fluid from the body. So urine is one thing. So you remove the excess fluid through urine. So how do you do that? Block the pump. Okay. So try to understand this, go back and just, I think I have the audio file also, just listen to that part. Okay, but it is a little bit more complex than this.
So again, ADH works on the
DCT and collect. Yeah, distal nephron. That's where the main action is. Main action is on the distal nephron, because that's when the body is able to decide, do I need to retain more water or do I need to throw it out? Okay. Some amount.
It all happens, but before all of that, that's what it. Okay.
Yes. This is just preparing the ground for this. That's all.
That's
Okay.
why the collector.
Yes. So, two terms. The water reabsorption that occurs in the proximal convoluted tubule, the water reabsorption is fixed here, I told you, because glucose is getting reabsorbed, amino acids are getting reabsorbed, so there's no way you can stop it. This water reabsorption that happens in the proximal convoluted tubule cannot be prevented. Even if your body doesn't want extra water, this will still be reabsorbed. Okay? The only place where the body can adjust the reabsorption is in the distal convoluted tubule and the collecting duct, under the action of ADH. So, the water reabsorption that occurs in the proximal convoluted tubule is called obligatory water reabsorption. So, those of you who are taking microbiology, I know some of my students are here and others are also taking microbiology, you must have learned about obligate aerobes and facultative anaerobes. Obligate means absolutely required. You cannot stop it, they need it. So, this obligatory water reabsorption cannot be stopped, it will happen. Whether you like it or not, whether you want it or not, this is going to happen. Okay? But this one, this is the adjustable reabsorption. Facultative means adjustable. Microbes can grow in the presence of oxygen or in the absence of oxygen. So that is facultative. Facultative means adjustable. So this is the adjustable water reabsorption depending on the needs of the body, which is brought about by the hormone ADH. So try to go over this, because I know always students get confused with the action of ADH. So this is an important slide. Okay, remember, when you have too much of water in your body, you want to throw it out. You don't want to retain water. So ADH will not be secreted under conditions of overhydration. Only when you are deprived of water, when your body needs extra water, ADH will be released and it's going to retain water, and then the urine that comes out is going to be a concentrated urine. Okay, so I will stop here. I think this is almost done. We have almost finished this part. The next one is your fluid and electrolyte balance. Okay.